activation of and survival of eosinophil. This one also TH2. So the last one we have is TSLP, this one. And interleukin-33 is not yet in the market. So TSLP is basically produced by the epithelial cells of the skin, of the mucosa. In the mucosa we have epithelial cell, right? And then epithelial lining of the lungs. So when they expose to this virus, exposed to this allergen and all that, this epithelial cell will produce TSLP, a cytokine. So this TSLP will cause the mast cell to burst. It induces the IgG process and burst the mast cell, and it also combines with TSLP receptor in innate lymphoid cells to produce TH2 cascade. This one is in process as well, and also it can direct request the dendritic cell to produce TH2. So all this is a process. So it can happen everywhere. So if you see this one, it will influence the lower one. So all this, it will influence the interleukin 4, interleukin 5, and especially the IgG in the body increase. So if you see here, which one will you choose? If you have one drug, you have to choose for patient, which one you want to choose? Anti-TSLP. So I think my talk is end here. You already have the talk end. So it's basically TSLP because it's cover everything. So from my experience, I don't have experience with TSLP because it's not yet in the market. And I have experience with omalizumab because it's covered here only. Some patients work, some patients doesn't work. Because some patients they have different types of etiology, right? And then dupilumab, many of patients works. Many patients works when I give this dupilumab when they have CRS with nasal polyposis and anosmia. So their polyp reduce, their anosmia also become better. So if you see, if I give dupilumab here, it works very well. Then what happens if I give the one that you know that produce everything from the top? It's like this one is the mother of all. Okay, they cover everything. But I don't have experience with that yet. Later maybe I have a mental drug and we give a second talk. Okay. So now we go to chronic rhinosinusitis with nasal polyposis. Especially when patients have chronic rhinosinusitis with nasal polyposis, it will affect the patient's quality of life and increase patient's burden of cost. And then patient will come to you with nasal obstruction, and then you have to give post nasal drip and all that. Okay. So about 4.4% of global population they have CRS with nasal polyposis, and 70% of them has olfactory dysfunction, and about 50% of them has asthma. So because it's related. Okay. So now is this CT scan show when patient has CRS with nasal polyposis, there are polyps everywhere, especially in the sinuses, pulmonary sinus, ethmoid sinus, sinus, and all that. So when the polyp is here, so it will block. It will block the breathing and also block where the olfactory cleft is. So some patients will have hyposmia. If patient has anosmia, it's different because it involves the cytokine and interleukin at the level of epithelium, olfactory epithelium. So this one is written because this slide is not produced by me. This slide is by the company. So I have to follow what is written. But I want to explain to you what is that. And if I don't explain, then I think people won't understand if I don't explain. So I want you to understand what is that. So in Western population, the T2 inflammation is predominant in CRS with nasal polyposis. T2 is basically eosinophilic inflammation. That means if you take the polyp, put under microscope, there will be eosinophil more than neutrophil or plasma cell. That's why it's TH2. So both T2 and non-TH2. So it's common in Asian population. So non-TH2 is T1 and T3. T1 is when we put the polyp under microscope, we see more neutrophilic cells and plasma cells rather than eosinophilic. And then T3 is a mix. Mix of neutrophil and eosinophil. Okay, so this polyposis, they will have anosmia. Actually, my interest is CRS with nasal polyposis and anosmia. If they don't have anosmia, actually, we give patient with all this medication, because if patients have CRS with nasal polyposis only, it's rarely patient that develop like depression, patient die and all that. But if patient have anosmia, like I think I talked this morning, patient can develop depression. That's why my interest, all patients with CRS with nasal polyposis and anosmia, then I will see the patient whether they eligible for biologic agents or not. The other one is biologic agent, is quite expensive. So all we know, right? So okay. So this one, we see the basal cell this morning, right? I told you. The basal cell to produce the olfactory neuron cell is very important. So this cell produce the olfactory neuron cell, this one. For the sexual cells olfactory neuron to produce that the one that will take the molecule order and bring to the olfactory bulb. So this one will produce this. And the sexular cell is to support the olfactory neuron cell. So if there is increase of interleukin 4, interleukin 13 in basal cell, so basal cell cannot function. When basal cell cannot function, it cannot produce olfactory neuron cell. So there will be reduced olfactory neuron cell in the epithelium. So that can cause reduce smell or hyposmia in the long term. So the other one is there is a lot of interleukin and cytokines in the olfactory mucus as well. This one will affect the function of the olfactory function. Okay, so usually patients with chronic rhinosinusitis and nasal polyposis is a standard. We will treat the patient with intranasal corticosteroid spray, 1 year, 2 years like that. And then we give corticosteroid therapy. We give corticosteroid therapy is 3 times a year. Every 3 months or every 4 months we give. But if we give longer, it's based on the study and based on our study also, if we give longer corticosteroid therapy, it can cause increased intraocular pressure. That's why we all know, right, corticosteroid. So that's why we try to go away from giving steroid therapy for longer. So we did a study, if we give more than 2 years, more than 3 years, they start to have the increased intraocular pressure. Yeah, and then longer term patient will develop a posterior capsular cataract. Okay, so if patient, because in Asia, in Malaysia, we have a non-type 2, non-TH, that means T1 and T3. That's why most of our patients will also use microlide. So corticosteroid therapy to cover the eosinophilic infiltration. But for neutrophilic infiltration, we give a macrolide. So macrolide we give 8 weeks. 8 weeks every 4 months. Every 4 months, 8 weeks. So we give for 1 year. If after 1 year of therapy, the symptom is not improving, then the patient will be opted for surgery. So maximum treatment is 1 year. If no improvement, then we opt this patient for therapy, for surgery. I mean. So many patients that we have to do a revision surgery, like that one is like some patient then we have to do multiple. Some patient, I think in my history, about for 20 years here, 8 times surgery for chronic rhinosinusitis with nasal polyposis because it keep on recurring. Okay, so what we give now, and now because we have a biologic, then either we want to put patient on multiple surgery, or patient or we don't have anosmia, or we have another option is biologic. Biologics is not all CRS and nasal polyposis to work with biologic, but we can try. Okay, so this one is about they give a biologic in their patient. About 12 patients receive a biologic agents, but some of them, 31% of them stop because it's not working. They have no benefit. Maybe omalizumab, because I'm not sure, because the previous is omalizumab and dupilumab. I'm not sure which one is not working. Yeah? So this one is the nasal polyp. In patient, when they do surgery, we see here the nasal polyp is keep on. When we try to remove all during surgery, but the thing is keep on increasing because it's an inflammatory process. And it's keep on growing. And then it's a revision surgery, and some days it's not control and all that. Okay, so now we talk about epithelium, and epithelial cytokines play a central role. I think Prof. Aniza talked about this morning as well, and I touched a little bit. You have 3 times saying, or like people tell you, I hope something like goes. That's not what I hope. Actually, this one is, I know it's difficult because all the cytokine interlinking, I myself, I don't like. So it's so detailed. So when this one is epithelial cell, right? Your epithelium exposed to these environmental triggers like allergen, virus, pollutants, bacteria, and others, and they start to produce TSLP. Yeah? So that's why it's simple. I will tell you start to produce that, and then this is the actually when they exposed to all these triggers, they produce. The skin, they produce TSLP, interleukin 33 and interleukin 25. But the thing is, these two, we don't have a priority agent yet, then we have this one. Okay, so actually this one is the same, what I told you from the beginning. What happened when the TSLP produce and it start to from all this interleukin 4, interleukin 13, IgE, and all. It's the same thing that I told you before. So this one is just to tell you about the type 1, type 2, type 3. Okay. This one is how the polyp is formed. This one is actually is like trigger, and then there is edema. And then all the cytokines come in and they start to develop edema and then polyp formation. That's all. Yeah? This one is nothing. This one just to say that 50% of patients with CRS develop polyposis, they have asthma. So if let's say patients have chronic rhinosinusitis with asthma, actually it benefit patients a lot. Asthma is a fatal condition. Some, like a physician, they will start patient on biologic agent if the asthma is very severe. So if they have polyp together, then this is good for the patient because we treat both diseases. Okay, this one to show that asthma and CRS polyposis show the similar patterns. They start to have swelling, blah blah, and all that. Okay, now we go to TSLP. So because today is about TSLP, so this one anti-TSLP. They call that tezepelumab. Okay, the same thing. Okay, this is the study of this paper. It's about TSLP, interleukin 25, interleukin now. Actually, the interleukin, I mean the TSLP is more in eosinophilic pattern rather than in neutrophilic pattern and the rest. Yeah. So actually, if you give a tezepelumab to patient with eosinophilic inflammation, it works better. So it's a study done overseas to show that how the TSLP result can be given to some patient with CRS with polyposis. So this is a patient, 408 patients. They give anti-TSLP and one patient and randomized one patient. The other patient placebo. For they give the study for 52 weeks. Yeah? So what they measure is nasal polyp score, nasal symptom score, quality of life score they is not, and then polyp score, and then what else? And then smell score. So this one they want to see whether it's improved or not at 52 weeks of treatment. So what they found, this one is for nasal polyp score. Nasal polyp score, inside there will be like nasal obstruction or secretion and all that. So the nasal polyp score is improved from 4 weeks in anti-TSLP compared to placebo. We see that this drug now, actually this one TSLP and this one is placebo. And this one is placebo, this one TSLP and this one is placebo. So it's like it's improved. And then easier than nasal polyp score. And this one is other scores. That means this one, the smell. The smell score is improved compared to placebo. The quality of life score is also improved compared to placebo. And also the CT scan score also improved. The CT scan score, they use a non-market CT staging. So this one is more to corticosteroid use, and then surgery is also improving, and less corticosteroid use and less surgery done. It's the same. And this one is smell score is improving compared to placebo. And this one is nasal symptom score also improved. Okay, this one is the CT scan. You can see before the surgery, the baseline is 18.5, and before the treatment. So after the treatment, the symptom score is 13. So you can see that reduction of the polyp score without surgery. There's no surgery done in this patient. So safety data. So you want to ask me, this one biology agent, is it safe or not? I think the first question you want to ask me is that, right? Because biology agent, is safe or not? I mean, this one is based on study for 1 year study. The side effect is, you can see here, allergic rhinitis, epistaxis, CRS increasing and asthma. Some patients, when you give biology agent, it will exaggerate the asthma. I think the last physician give a talk now. All, when they give all biology agent to patient, all stop because asthma becomes severe post biology agent. Some people happen like that. So how about others? This one is 3-year study. A 3-year study show that some patients, this one met the any malignancy is about 4, but in placebo about 3. One probability or 0 in biology and 1 in placebo. Asthma related 0 and 1. So this one the data that I have. So if you ask me, is there any proof that patient develop lymphoma and all that, I can answer because we don't have a long study to prove if we give a biology agent, patient can cause cancer. Summary, desacrylate is a good drug. Basically, it's a good drug to improve the CRS with nasal polyposis and anosmia or olfactory dysfunction. And then it reduces the corticosteroid usage and reduce the surgery and all that. So I think that's all.